so now let's talk about the endocrine glands and their hormones. Okay? So I like to start from the top and work our way down. There's no way I'm going to finish all this today. I still have Monday and Wednesday to do it with you guys, but you've got to get started with this. All right, so the hypothalamus, okay? This again is where the nervous system and endocrine system, they interconnect with each other, okay? And like I said, the hypothalamus is going to do releasing of inhibiting hormones and releasing hormones, right? If it has the word releasing in the hormone or inhibiting is coming from the hypothalamus. Now, there's 7 major hormones that come out of here. TRH, we kind of mentioned before, the thyroid releasing hormone. We also mentioned gonadotropin releasing hormone, right? GnRH. I should have pictured this. All right. Now, there are 2 hormones, and by the way, all those hormones that get released from the hypothalamus will always, always, always target the anterior pituitary. Always. Okay? However, there are 2 hormones that are made by the hypothalamus but don't get released by the hypothalamus. These are ACTH, or antidiuretic hormone, also known as vasopressin, and oxytocin. These 2 are made in the hypothalamus and then pass through your hypothalamus is here, and then you've got this stalk called the infundibulum, and then you have the posterior pituitary here and anterior pituitary here. So what I'm saying is there's hormones that are made in the hypothalamus that get released into the bloodstream by the hypothalamus, and all of those will target the anterior pituitary. However, there are 2 hormones, ACTH and oxytocin, that are made by the hypothalamus, but they travel down the infundibulum and they get stored in the posterior pituitary. And when the time comes, ACTH and oxytocin get released by the posterior pituitary. These get released in green into the bloodstream to eventually get to the anterior pituitary. Okay? Questions on that? So these are the hormones that get released from the hypothalamus. The ones I have here like in green. TRH and GnRH, those things. All right? So kind of like what I just drew for you. We have some hormones that get released. Here's the hypothalamus. Here's your pituitary gland. Here's your anterior pituitary gland. And some of the hormones that get released by, or all of them that get released by the hypothalamus, they will all go through the bloodstream and go into the anterior pituitary. But there are 2 that are made in the hypothalamus but travel down the stalk, or the infundibulum, and get stored and then later released by the posterior pituitary. And that's ACTH, antidiuretic hormone, also known as vasopressin, and oxytocin. All right. Other things that you learn from AMP1 is that there's going to be also some sympathetic control, and we're going to send things through the autonomic nervous system. Remember the good old preganglionic fibers? They go right down to the adrenal medulla to release epinephrine and norepinephrine. But that should be old news to you guys. All right? So that's basically just, you can read that on your own, but it's just saying here, like in the green, it's going to get released into the bloodstream, these hormones, and go right to the anterior pituitary. Other ones, they get made in the hypothalamus, but get stored in the posterior pituitary. right, and you've seen this picture before. Just showing you the three mechanisms of the hypothalamus of release. Hormones that go into the bloodstream to the anterior pituitary, the ACTH and oxytocin go to the posterior pituitary, and then we have some fibers that go to the adrenal medulla, release epinephrine and norepinephrine. Okay? All right, now let's talk about the hormones of the anterior pituitary. Hormones that come out of anterior pituitary, and there's 7 main ones. Okay? Now, all the hormones that come from the anterior pituitary, they're made there, they're stored there, and they get released from there. They're called tropic hormones, also known as tropins. We all learned from A&P1, in order to master A&P, you need to know how to say one structure about 12 different ways. Right? You know what I'm talking about? You don't. You got you just had, what is it, the alkaline tide is just hitting, you don't even know what alkaline tide is. You made a big meal, now you're tired. We'll talk about the alkaline tide when we get to digestive system. That's what that is. All right, but all the anterior pituitary hormones are tropins, and it all gets stimulated by hormones from the hypothalamus. Okay. So let's talk about the first one, growth hormone, GH. It's also known as somatotropin. Look at this, GH, somatotropin, growth hormone. It's the same thing. That's what I'm saying. You got to know how to say one structure about 12 different ways. All right? And you got to know them all, because I can't just call it a growth hormone and then you go into some other course and they don't call it that, they call it somatotropin. Now that's bad on me because I didn't teach you it. You see what I mean? You just need to know all of those. I don't care what you write on your test. I mean, multiple choice, it's obvious what you put on there. But if there's a blank space there, you want to call it somatotropin, GH, that's fine. I have no problems with that. But you need to recognize the other words, though. Okay? So what does this do? It's going to stimulate cell growth in all body parts. Okay? So it increases height and weight in puberty also. You get a high... You always have growth hormone coming out. It goes like this. But during puberty, it goes out faster, and then it goes back like this. You have that growth spurt, right? So these are the things that growth hormone does. Okay? Pretty straightforward on it. You can read that, but it's straightforward. You're going to build protein synthesis and stuff. So, once you understand what growth hormone does, all right, you know growth hormone. Looks like that chart, right? The chart that I gave you. This is where you start building up on here. Growth hormone, where does it come from? The origin. It's anterior pituitary gland. Where does it target? All cells. All right? Because it keeps on growing. Okay? The function. It's going to make cell growth. You can go into details and say specifically what does it do. Increases tissue growth, increases fat breakdown to put glucose into the bloodstream. That's right. Okay? You can increase glucose synthesis. Right? You need glucose to make more cells. All right? Increases protein synthesis, decreases protein breakdown. Okay? So it's that kind of stuff. But what happens, now this is where I twist it a little bit, because if you know the function, you know diseases. If you have growth hormone and you know the function is supposed to make cells grow, then if you have a tumor to the anterior pituitary specifically for the cells that produce growth hormone, then you have an excess of growth hormone. Makes sense. But we have two different things, because it depends on if you have a tumor before puberty or after. Well, not puberty, but before the growth plates fuse. Remember the epiphyseal plates in the bone? Okay? If you have a tumor before then, you have a different presentation than, let's say, someone who's, let's say, 40 years old that produces this. Let me show you what this is, and it'll make sense to you. All right? So the symptoms differ with growth rates fused or not. If they're not fused, so this is a child at, let's say, 15 years old, then what's going to happen is everything's going to grow at the same rate, but excessively. They'll be in proportion. Their arms and legs will be in proportion. It's just that they're going to be very tall. We call this gigantism. So you have this symmetrical growth. We usually see it in children. They're just very tall. Here you're at 12 years old, but yet you're 7 feet high. Now, it could be. Don't get me wrong. I don't want people to think, oh, my God, my child's got a brain cancer or something like that. No. The thing is, if you have tall parents, if your genes, you have tall, that could be the reason. But if you have everyone short, you're getting this big, that's a concern. It's simple. We just got to do a growth hormone level and see what that is like. You know, kind of like the thyroid function test that I showed earlier. So the growth plates keep on growing. So you're going to have long arms, well, not long, but you'll grow in proportion. As opposed to someone who's, let's say, 40, 45 years old, who develops a tumor on here, well, the growth plates have already fused. You can't do anything more with that. So instead of growing this way, you're growing with ways. Now, I'm telling you, I've been talking about bones, but it's not just bones, it's everything. Skin, nose, everything. Heart, everything grows. So in this case, we have a disease called acromegaly. Acro means arms and legs, limbs. Megaly means megaly, like megaly, gancha, like big. So it's basically the limbs enlarge. So we call this acromegaly. And we usually see more features in the face. We see it in the palms too, but the fingers are more like short and stubby, almost like their hand. And I'll show you pictures, but they're like spaded. Like a big spade is over here. You'll see they're shorter than what you expect. Not long fingers. All right, you have excess, like the tongue grows bigger. You'll see all this. They also have hypertension. Now, let me explain to you about the heart here, and we'll get into it in a couple of weeks. But the heart is actually 4 chambers. And there's a chamber over here, there's a chamber here, chamber here, and chamber here. This is a wall. And blood goes in here. So blood will go into this one, and pump out. Blood will go into this one, into here, and pump out. So it's 4 chambers. Now, if someone's got acromegaly, everything grows. So the heart wall is going to grow, and I'll put it in a different color here, is going to grow bigger, thicker, so that it can compensate for a bigger body so that the heart can push more blood forward. So you have this heart that's growing bigger over here. So it looks fine and dandy. However, I'm only showing one side of it. This whole muscle starts growing bigger. So this wall, and just visualize it on this side, is going to start looking like this. You see what I'm saying? So even though the heart is getting bigger, the chambers are getting smaller. And it can't compensate for this huge body. And that person will develop high blood pressure because there's too much blood, too much blood out here that's backing up. You can't get it that way. So now you can't push this blood forward, enough blood to go all over the body. Does that make sense? All right? So they have heart defects. So this is gigantism in a child. Here it is at 15 years old, and the kid's like 7 feet tall. Okay? Acromegaly, they have a kind of a distinct facies that you can almost pick out. They have this, the ears are long, they have the jaw that's protruding out like that. The jaw gets bigger. A lot of times their teeth are falling out because the spaces that hold the teeth get bigger, so the teeth fall out. Their skin on their forehead gets bigger. Their tongue gets bigger. You can see the jaw, how it's protruding, that's out bigger like that. All right? They kind of cover the eye so you can't say who it is, but they should have done a better job, right? But it's just showing you the tongue is much bigger. They lose a lot of teeth. They get a lot more spaces in the teeth. Here, trying to show you the hands are like spades. See how they're like short and stubby? Like, all right, that thing there. You can see it here. Here's a normal foot. Here's one that's bigger. They have all this extra skin because it's so much growth that occurred. Here's a person that could come to me and say, you know, just go for a routine exam. I've never seen this person before. It came to me for the first time. He looks fine, no issues, but his blood pressure is 200 over 100, which is pretty damn high. But he doesn't know it, all right? Most common presentation of someone with high blood pressure is that you don't even know you have high blood pressure. There's no presentation, all right? So he comes to me with a blood pressure of 200 100, pretty high. So he needs to be stroking out soon. So my idea is to try and come up with, well, what's the cause of this? Now, most cases, about 90% of cases, there is no cause of high blood pressure. It's called essential high blood pressure, or hypertension. But I do notice that when I look at him for the first time, there's a certain facies that he has. I've never seen him before, but he has certain features that I'm noticing on him. Ears a little bit big, protruding jaw, lips are big. Now this could be him, and that's very fine and dandy. I'm not picking on anyone or discriminating. I'm just saying, just having keen eyes. And I would just say to him, can you just do me a favor? Do you have any older pictures of you? Not, but fairly recent. He's like, what? Well, he did. And he had a picture when he graduated college 2 years ago, and he got married last year. Do you see what's happening here? Do you see the differences? That's why I look at people and have it. I look at all of you, and I know what you have, and I know what you have, and I know what no. I do that a few times. I can't help them. On the subway in New York City, I'm just sitting there for 20 minutes. I'm looking at people. Nothing wrong with that. I'm not discriminating, but it's just the way I'm trained. I look at people and have an idea of what they are, what they have. And maybe not. I don't go up there and say, I know what you've done. I don't get slapped or shot or something like that. But it just keeps my mind going. I'm saying, oh, that's what that looks like. I've seen pictures, but that's what we probably have. You know. So, yeah, I've had a couple students actually say, you know, you accept the challenge? I said, what challenge? I said, well, guess what I have? Oh, my. And I was able to guess like a few times and actually get it right on the mark. They pointed out that there's something wrong. So now I'm looking, I'm saying, you know, I said, have you got any broken bones lately? He goes, yeah, you know what I have. And it's osteogenic imperfecta. I see the gray in the eyes, and this glare of the whites of the eyes. I can see things like that. So it's just something when you get into the medical field, you'll start doing that, and you don't want to. It just happens, and naturally, you just do that. I know what you have, and I know what you have. All right, but that's the kind of thing you got to be keen with that kind of stuff. You go into the medical field, if you could pick up something. Hey, if it's someone that you could actually say something to, like your father or mother, right? Your father, you're noticing he's putting on a lot of socks all the time. You see him going to the bathroom a lot and drink a lot of soda. He wants his cold cuts. Dad, you know, why don't you get your sugar checked? You start realizing that those are signs of diabetes. Now, I'm not saying he has it, but if you could pick that up and catch it at an early sign, you're going to save some lives. Okay? So anyway, so you get a picture on that. Now, anybody know who Tony Robbins is? You know, he's been in a recent movie, Shallow Hal. He's a motivator, right? He's one of these. He has a deep voice. He's very tall. Many girls say, "Oh wow, look at him. He's got that. You know, he's got the jutting jaw, and he's got those, you know, manly features that people just look at. It's like, you know, even I'm looking at him like, you know, he stands out. He's a motivational speaker. He has a deep voice, and he gets people involved, and he has all that. Now he had what happened with him. He's very tall. And you can see some features on him. What happened with him, and I'll just go right to I'll cut the chase, and I'll go right to what he had. He found out he grew to a certain height, And they found out that he had a tumor, he had an anterior pituitary tumor. And if you remember, the pituitary gland sits in a bony structure called a cellulosical, this sphenoid bone. And it sits in there. Okay? Now what happened was, blood flow was going to this tumor, it's getting big and big and big. So what they did was, they didn't know anything about it until about 23 years old. Maybe 23, 24, something like that. And they took a CT scan of his head, CAT scan of his head. And they noticed that there was a tumor there in the anterior pituitary, but the tumor died. What happened here, and it was just coincidental, as the tumor got bigger and bigger, it was pressing against a bony structure, and the blood supply, the blood vessel that was actually giving a lot of blood to the tumor, got impinged between the tumor, which is getting harder, and the bony structure. So it's stopping the blood flow to the tumor. Does that make sense? You're impinging it. So what happened was, eventually it stopped the blood flow to the tumor, and the tumor died. So they said to him, look, we could do one or two different things. We could go in and we could remove the dead tissue, or we could just check you for, we'll do CT scans once a year until maybe like 10 years or so, until, nothing else is growing on there, and see where we go. And he chose for option B, but he wasn't going to grow anymore. But that was the coincidental thing on there. Does that make, I wouldn't ask you about that, but that's where that happens in there. Again, physiology reflects anatomy. Kind of makes sense where this is all happening. Andre the Giant, you know him, right? Wrestler back in the 70s, right? And then he became an actor. What was the movie with the Princess Bride, right? He was on there. And he's a French guy, and he's really big. One of my buddies knew someone who met him. He died now, but he said that his hands. He put his hand on a can of beer. You can't see the beer. It was that big of a hand. All right. And to give you an idea of the size of his heart, the size of your heart, if you make a fist, that's about the size of your heart. So he made a fist, you can imagine how big his heart is. Okay? Now what happened with him was that he had gigantism when he was a child. So he grew this way, they didn't do anything about it, and then when his growth plates fused, now he started growing this way. So he has features of both gigantism and acromegaly. So he's tall, yet he's also has, you can see his facial features too, the jutting jaw and all that stuff. All right. Anyone know how he died? It was the heart. Yeah, the heart tissue, the disease. His blood just can't deal with all that extra. As you get older, the blood pressure that you get and stuff. So he died of heart failure. Okay, because of that reason. All right. Again, I won't ask you about those, but those are kind of interesting things to get. And I do that a lot when I do diseases and when I talk about certain things. I always put celebrities. A lot of people, students, remember the celebrities. Oh yeah, he had this and that, and you start remembering that. In AP1, I did Bob Marley, who died of melanoma and stuff like that. So, also had who's the Wolverine? Hugh Jackman. Yeah, he had basal cell carcinoma, so I put him in there too. Those kind of things. Psoriasis was, I lose track on one of the Kardashians. She's got psoriasis. But anyway, questions about this? All right. So this is I did this kind of slow for you because that's the way how you should do it. Know the hormone, the origin of it, where does it come from? The target, where does it go? And then the function, you should know the function. And then if you have too much of it, what can happen? Don't memorize. You don't need to memorize that part. Maybe to memorize, let's say, the words, gigantism or acromegaly, but it should make sense what it does. Now we got to do the opposite. What happens if you make too little of it, right? Well, one other thing I forgot about this. One other thing I just want to say about if you have a tumor of the pituitary gland. Where it sits, if you remember back in A&P1, you have the optic chiasm over here, which is basically the two optic nerves cross over and they attach to the eyeballs. Where they cross over, that X is called the optic chiasm. The pituitary gland sits right in between there. So So what's going to happen is if this pituitary gland grows because of a tumor, it's going to press on that optic chiasm, and what's going to happen is you're going to have visual disturbances too. In essence, they become tunnel vision. They can't see over here, but they can only see straight forward. So that's why you put that stuff together. Can you see me? Maybe, you know, I'll stand on the other side of him. Can you see me coming here? If you're losing peripheral vision, you have high blood pressure, you have these features, you got to start putting all this stuff together. And this is the kind of stuff that I'm seeing NCLEX, the nursing licensure exam, is starting to do. Well, starting to do, it's been doing it for about 4 years now. 10 years ago, they didn't have all this diagnostic kind of stuff. Now they're putting it on. They wanted to see if you could actually recognize this stuff, because we're seeing more and more nurses becoming nurse practitioners, and you've got to see this stuff. Okay? All right, so what about the opposite? What if we have a decrease of growth hormone? If you have a stroke to the area and it's not going to produce growth hormone, what happens here? All right, so in children, we have something we call dwarfism. Now, there's a lot of reasons why dwarfism would occur. Okay? Achondroplasia is the most common one, which you should learn in AP1, but I'll show you that in a moment. But what about this? Pituitary dwarfism. Basically, what's going to happen is there's going to be less growth hormone going to all your tissues. In this case, they're just going to be little people. In other words, they're in proportion. Their head is proportionate with their torso, proportionate with the legs. It's just a small person. Achondroplasia, which I think I have over here, dwarfism. Yeah, achondroplasia is the most common form, and that should have been taught in A&P1. What happens here is the growth plates fuse too early. They fuse at 2 years old, at 3 years old. So their long bones can't grow lengthwise anymore. But their head and their torso, that's not long bones. So that's going to grow appropriately. So you have the head and you have the torso as an adult size, but then you have the arms and even the fingers, the long bones, are short. So they're not in proportion, right? And I'll show you pictures of what that is. All right, pituitary dwarfism, that's what I'm trying to explain to you. That's where the whole body is. So this is achondroplasia, okay? You know this guy from Game of Thrones, right? You can see here, the head is the same size as the adult head. The torso is the same size, but the arms and the fingers, the legs and the feet, you can't see the toes, they're short. Those are where the long bones are. That affects the growth plates. That's the most common form of dwarfism. Okay? Pituitary dwarfism is because a growth hormone is not coming out. And you can see here, the head is it's not the same size as the adult. Well, that's an adult too, of an adult size. So, you know, people say, oh, how cute that. Keep in mind, he's probably about 50 years old here. Okay? That head is in proportion with its torso and legs. It's just a short person. Does that make sense? This is because it goes to all the tissues at the same time. The fingers, the legs, the arms are all in proportion of what the head and the torso is. Okay? Again, I look at people, I have an idea what's going on. I wouldn't go up to them and say, oh, I know what you got. You got low GH. Like, how do you know? All right, questions about that? All right, thyroid stimulating hormone. This is another hormone that comes out of the anterior pituitary. Not going to spend too much time on this until we get to the thyroid, but this is going to tell the thyroid gland to release T3 and T4, which controls metabolism. Okay? We also have adrenocorticotropic hormone, all right, ACTH. This is going to tell the adrenal cortex to secrete its 3 hormones with a majority of cortisol coming out. Okay? We also have FSH, follicle stimulating hormone. In females, it acts on the ovaries to develop these egg sacs called follicles, produces the mature egg or ova, and secretes estrogen. In males, it acts on the testicles or testes, and this is what's going to make sperm. The sister hormone to FSH is LH, also dealing with reproductive systems. In females, this is going to trigger ovulation. And once that egg pops out of the ovary, that's ovulation. The area that it just came out of the ovary is an important area. It has a new name. It's called the corpus luteum. And that corpus luteum is also going to release hormones, which we'll get into the reproductive system. Okay? But yes, hint, hint. LH triggers ovulation. In males, it secretes testosterone from the testes or testicles. Okay? So you can see, if you're doing that chart I gave you earlier, you're going to have to split up things because it's male and female. Right? Prolactin is another hormone from the intravenous cortex. I'm sorry, from the anterior pituitary gland. And this is going to make the milk glands grow. Okay? And it's going to make the milk. It's going to make the milk. Not going to inject it. It's going to just make the milk. And then this other one, melanocytes stimulating hormone. It's not truly a significant one. It's really not produced in adults. However, in pregnancy, remember, this is going to make the melanocytes produce melanin and become darker. In pregnancy, it does stimulate the melanocytes a little bit more. And if you've been pregnant, maybe you have freckles that became more pronounced. The areola around the nipple, they get darker. And in most women who are pregnant, and if you've been pregnant, or you see your mom and she's not wearing a shirt, you know, like you can see her belly, there's a line that grows from, a darkened line that grows from the pubic symphysis up to the belly button. We call it linea nigra, which means black line. And that is absolutely defined that you've been pregnant sometime in your lifetime. Most women get that line, and once your pregnancy is over, it usually stays there. It dims a little bit, but it was always there, or it usually stays there. Okay, so be careful what you tell your doctor that you were never pregnant, and we see that line there. That's why we get an idea of, you just be honest with the doctor. All right, we want to help you, you know. But if we have an idea that you're lying already, like, you know, just be careful with that. All right, we're not going to catch you on that, but we know that we need to ask these questions in a roundabout way to get that. All right, but that's what that is. You don't have to raise your hand, but yeah, if you know someone who has it, that's what that is, that you've been pregnant sometime in your life. All right, so let's talk about the posterior pituitary gland. All right, we talked about this already, so I'm not going to bore you anymore with the antidiuretic hormone. All right, you understand what I wrote up here. Reabsorbs water from the kidneys and makes your blood pressure go up. Do make sure you understand the mechanism of that as I drew that for you. Okay, and it's also known as vasopressin. Vaso meaning blood vessels, pressing like you're pressing down on it, constricting it. That's how I remember it. All right. And again, they're showing you the functions of it here, which I did already. Now, if you have too much ADH, right? Let's do this again. All right, very quickly. ADH. Antidiuretic hormone means you're not going to pee, right? So that's going to make your urine go down, which means that your blood volume will go up, which means that blood pressure will go up, right? And then I also show that vasoconstriction of blood vessels, right? It's going to do that too, which will lead to high blood pressure, right? Now, if you have too much ADH, look what's going to happen here. If you produce too much of this ADH, and the most common reason of this, believe it or not, is lung cancer. Well, what happens here, it's called syndrome of inappropriate ADH, or SIADH. And the most common reason is lung cancer. MCC stands for most common cause. There's a certain type of lung cancer that produces an ADH-like hormone. And it's going to turn on the ADH receptors in the kidney. That's what happens here. Okay? Interesting phenomenon. So if you're going to increase ADH, what's going to happen to your urine? It's almost like you're not even going to pee at all. What happens to the blood volume? Highly going up, which means it's going to raise your blood pressure so much that it's going to cause hypertension, high blood pressure. Make sense? Okay? Now what about if you have a deficiency of ADH? Now, this deficiency is called diabetes insipidus. Now, this is not the same diabetes as grandma's got. This is a rare occasion. Well, grandma's got is probably something called diabetes mellitus, which we'll get into about insulin. Diabetes insipidus, for whatever reason, you're making a decrease of ADH. Maybe a stroke to the posterior pituitary and you're cutting off blood supply and now the ADH is not being produced. So you're going to decrease the amount of ADH coming out of here. Which means what happens to the amount of volume of urine? It's going to go up. Which means what happens to your blood volume? It goes down. What happens to your blood pressure? Yeah, you're going to have something called hypotension. You have low blood pressure. Now, I don't know why they call it diabetes to actually confuse you, but I don't know if diabetes means that you're going to pee a lot. Because in both diabetes mellitus, which is what grandma's got, or diabetes insipidus, you're going to pee a lot. The only difference is that diabetes insipidus means no glucose in the urine. Diabetes mellitus means the urine has sugar in it. And back in the 1800s, that's how they tested it. All right? I wouldn't recommend that, but hey, that's the major difference between the two. Well, not the major difference, because it's also the mechanism. But that's what that is. So diabetes insipidus, very rare, but you should understand the and really, if you understand the function of how ADH works, then having too much or too little, that's easy stuff. Right? It just gives, if you understand excess and you understand the deficiency, I know you know the function. It gives the normal function meaning. That's why I put this clinical stuff in there. Okay? So, if you're losing a lot of urine, you're losing a lot of water from your body, you're going to get very thirsty to replenish your body. So polydipsia is a fancy word for increase in thirst. Polyuria is that you're going to increase the amount of urine that you're producing. And in both diabetes mellitus and diabetes insipidus, you will get that both. But this is very rare that should happen. These are the cases you would find on House and Grey's Anatomy and things like that. But don't throw that out. There's a possibility. Okay? Cool? All right. And the other hormone that comes out of the posterior pituitary is oxytocin. Keep in mind, ADH and oxytocin, where are they made? Where are they made? Hypothalamus. Where are they secreted? Posterior pituitary. Good. Okay? Oxytocin is going to stimulate the uterus to contract, to give you those wonderful contractions, to push the baby out. And also, this is what's going to eject the milk from the breast, not make the milk. Prolactin makes the milk. Okay? And that's just showing you where they target.